Good afternoon. I'm Dr. Rohan Chaudhary. I'm from Medanta Liver Institute, India. Last year, I got an opportunity to visit Japan under the Observership to Japan program during the APHPBA 2017. During that time, I got an opportunity to conduct a survey under the supervision of Masakazu Yamamoto. So the survey topic is Preoperative Management Protocol for Perihilar Cholangiocarcinoma, a survey of 2,778 cases in Japan. The operative mortality in Japan for perihilar cholangiocarcinoma has significantly reduced to less than 5%, whereas other centers in the world have reported up to 15%. So there was no major surgical technique difference which I saw. The major difference was in the pre-op management. So a questionnaire consisting of 20 questions was sent to 10 institutions. These 10 institutions were selected based on their case volume, years of experience, and research publications. So the questionnaire covered the following topics: pre-op biliary drainage, bile replacement, synbiotics use, remnant liver volume enhancement, predicted remnant liver function, imaging for surgical planning, nutrition, and role of Inchin Koto. So, to prevent post-hepatic liver failure after major liver resection for perihilar cholangiocarcinoma, the main thing is to control the sepsis, preoperative sepsis, by address properly the preoperative cholangitis and other infections, and use of synbiotics. And second most important is the remnant liver volume and the remnant liver function. The preoperative biliary drainage imaging to prevent remnant liver vasculature and achieve R0 resection. And last is the patient demographics, age, nutrition, and performance status. So 10 institutions participated: Nagoya, Tokyo Women's, Tohoku, Shiba, Yokohama City, Hokkaido, Shizuoka Center, University of Tokyo, Niigata, and Kyoto University. The median year of experience was 18 years, ranging from 17 to 43 years, and the median case volume was 226, ranging from 105 to 889. So all centers, 80% of the centers do ENVD for preoperative drainage, and 20% do endoscopic biliary stenting, 0% do PTBD. So ENVD has many advantages. It is a type of external drainage where you can examine the color of the bile, and any external drainage was accompanied by bile replacement immediately or within 3 days of external drainage. And there was lesser incidence of tubal blockage because of the regular flushing, and there was lesser incidence of cholangitis compared to the ABS. EBS is a type of internal procedure where cultures could not be pre-op cultures could not be sent, but the success rate was higher than the ENVD. None centers choose PTBD because PTBD of the remnant liver can cause injury to the remnant liver portal vein, causing PVT and excluding this patient from surgical resection or any fistula, artery biliary fistula, or and also tumor dissemination in the long term, which has been proven in many studies. All institutions preferred drainage of the unilateral region, that is the future remnant liver. Bilateral drainage was, including the low plan for resection drainage, was considered when there was uncontrolled segmental cholangitis, or when the fall of bilirubin was inadequate. It is postulated that unilateral drainage promotes the functional reserve of the future remnant liver by decreasing the function of the low plan for resection by compression of the portal vein branches secondary to the bile duct dilatation. Then This image here, the example of unilateral drainage, single ENBD, double ENBD, and bilateral drainage. Two institutions that prefer stenting, endoscopic stenting, consider the use of plastic stents, and if the drainage is ineffective, they change it to ENBD. 6 out of the 8 institutions that prefer ENBD uses endoscopic biliary stenting if more than 2 areas needs to be drained, and the other 2 institutions used up to 3 ENBDs. So whenever the patient developed cholangitis or due to catheter obstruction, the catheters were immediately exchanged or additional ENBD was inserted. PTBD is considered only when these procedures failed. For future remnant volume enhancement, all institutions preferred PVE, and the medium cutoff value percentage of the remnant liver volume for PVE was less than 40%. 2 institutes considered 30% as the cutoff, and 35% when it was HPD or hepatic artery reconstruction was involved, or in high-risk cases such as old age and multiple comorbidities. The medium cutoff value for the total bilirubin at which the PVE was performed is less than 4 mg. Interestingly, 2 centers performed when it was less than 10 mg. The median interval between the PVE and surgery is 3 to 4 weeks. All institutions...
you have to move on because you're short of time.
All institutions preferred ICGR test. 50% used inching koto, 50% didn't. Inching koto is a herbal medicine with hepatoprotective agent, genipin, which helps in the liver function post-operatively. So this is my conclusion. So ENBD is the procedure of choice for the strong recommendations are ENBD is the procedure of choice for pre-op biliary drainage. Unilateral drainage of the future remnant liver should be done. Bile replacement should be given immediately within 2-3 days. And bile culture sensitivity should be performed, and its result should be used as a guide for antibiotic usage in the perioperative period. PV should be done. ICGR 15 is a reliable test, and CT and direct cholangiography can comprehensively help in surgical planning. The weaker recommendations are use of inching koto and use of synbiotics in pre-op period.
Thank you very much. For want of time, I think we'll move on to the next presenter.
Thank you.